Our next speaker is Dr. Vignesh Murthy, who is a hematologist working as part of the Adult Bleeding Disorders Program at BC in Yukon and the Adult Red Cell Disorders Program at BC. He recently completed the Nieman Vickers Fellowship in Classical Hematology at UBC in 2024 and now joined the Provincial Red Cell and Bleeding Disorders Program as an attending physician. Dr. Murthy will be speaking to us about sickle cell disease, Canadian perspective. Thank you. Welcome.
Okay. Hi, everyone. Is this working? Okay, perfect. I will try to keep this to time, but please cut me off if I go over. Disclosures. And so, what is sickle cell disease? So, ultimately, sickle cell disease refers to a family of disorders characterized by sickling of red cells, leading to 1, chronic hemolysis and chronic hemolytic anemia, and 2, end organ injury due to small vessel occlusion. Most common variant being due to a homozygous inheritance of this point mutation in the 7th codon of the beta globin gene, resulting in this GLU7-val. And the astute audience members may recognize that they were taught something about the GLU6-val mutation. It's the same thing. What changed is the notation. We're now including that start codon as part of our nomenclature, and so GLU6-val became GLU7-val for anyone who is curious. In any case, where did this come from? The most common mutation that causes sickle cell disease also happens to protect against Plasmodium falciparum malaria when inherited heterozygously. So that's why, and likely why, it evolved and became prevalent in sub-Saharan Africa, but also in the Mediterranean, Middle East, and India. Unfortunately, when inherited in homozygous fashion, that results in sickle cell disease. And of course, due to the slave trade and global migration, patients with sickle cell disease can be found all across the world, including and especially in North America. This graphic just kind of illustrates this idea of oxygenated hemoglobin, where the HbS is not polymerizing, and then in deoxygenated state, it does polymerize, cause that sickled shape of the red cell, leading to hemolysis, cellular adhesion, inflammation, and vasoocclusion. This is what it looks like in vivo, where you can see the double arrow pointing to, I wonder if you can see my arrow here. Oh, yes you can. So you can see this right here, an actual sickled cell in a blood film that we can just see in the lab anytime. And here, there's some markers of functional asplenia. So where are patients with sickle cell disease? Globally, there are about 7.74 million as of 2021 worldwide. There's no great American data, a lot of it's estimates and modeling, with most people coming up with a number somewhere between 90,000, 100,000, 110,000. So that results in a population prevalence of about 1 in 3,400. In Ontario, they actually did a database survey using mostly emerge visits, and they found about a population prevalence of 1 in 4,200, give or take. In BC, our numbers are a bit lower, but we also haven't done a database study or anything like that. So we just know that 170 patients are followed in the adult program and 110 in the pediatric program. And sickle cell disease, of course, is a multi-system disease, and I'm not going to belabor this slide. Mostly just have it here to illustrate that if you can name an organ system, it's affected. And what I'm really going to highlight is actually pain. Because pain is one of the most well-known and common manifestations of sickle cell disease. And that's the vasoocclusive crisis, an acutely painful episode caused by bony infarction. So exquisitely painful. They can occur as often as once a month or every couple of weeks, and they frequently require patients getting admitted to hospital for IV pain control. And so over time, a number of patients with sickle cell disease can also develop chronic pain syndromes, which, as we know, are very difficult to treat. So pain is a big problem. And of course, it significantly impairs their quality of life. So these folks took physical functioning domain score specifically from 2 of these quality of life surveys, and they compared them in adults and children with sickle cell disease as compared to other folks with various other medical conditions and healthy adults and children. What they found was that adults with sickle cell disease have a quality of life somewhere between having adults with cancer on treatment and poorly controlled asthma in terms of their physical functioning. And in the pediatric realm, it was pretty similar to having cancer on active chemotherapy. So pretty bad. And it's not just the quality of life, their quantity of life is also decreased. So we know that life expectancy and quality-adjusted life expectancy are decreased by up to 20 and 30 years respectively in patients with sickle cell disease. And that directly translates to reduced income, lifetime income, they lose about 1/3, they have about 2/3 of the income of their sort of non-sickle cohorts. And this is purely imputed based on the reduction in life expectancy. So it doesn't account for frequent hospitalizations, the difficulty holding a job because of medical visits, medical appointments, tests, treatment, in addition to the hospitalizations. So the numbers here are, in fact, probably grossly underestimating the impact on our patients. And of course, there's a number of barriers to care in sickle cell disease, from systemic racism and implicit bias to lack of clinician knowledge, a perception of patients as opioid seeking. And on the patient side, and of course, lack of funding and access to therapy. On the patient side, there's often poor socioeconomic status for the reasons I already described, medical mistrust, and poor health literacy and medical misconceptions around some of our treatments for understandable reasons. And so these factors together make life very challenging and make accessing good care very challenging for patients with sickle cell disease. But what do we have? Like, what can we treat them with? So hydroxyurea is the main disease-modifying therapy in sickle cell disease. It was the only FDA-approved treatment for about 20 years, from 1998 to 2017. It does have a number of evidence-based benefits, from decreased vaso-occlusion and acute chest syndrome, decreased need for transfusions, and improved overall survival. So very effective. But there are other treatments with caveats. Crizanlizumab, for example, is a p-selectin inhibitor, which reduces endothelial adhesion. Unfortunately, has mixed evidence. A phase 2 study showed that it decreased vaso-occlusive crises, but a subsequent phase 3 study showed no difference versus placebo. So in the end, the European Medicine Association and MHRA in the UK withdrew approval for the drug in 2023, 2024, and it's been pulled from the market in the EU and the UK, although it does remain FDA approved as of now. Other therapies, including voxelotor and L-glutamine, also have been studied. So voxelotor stabilizes HbS in the oxygenated state, with a phase 3 trial showing increased hemoglobin in patients taking the drug. However, subsequent post-marketing surveillance showed an increased risk of both vaso-occlusion and mortality. So Pfizer actually voluntarily withdrew the drug from all markets as of September 2024, and it is no longer available at all. L-glutamine reduces oxidative stress, and there was a phase 3 trial that showed reduction in vaso-occlusion and hospitalization. This is pharmaceutical-grade L-glutamine, by the way, not stuff you can buy from Costco. But that study was criticized, unfortunately, for its analytical methods, including the way they handled patients who dropped out of the study, of which there were many, unfortunately. And so ultimately, it's only FDA approved. Both the EMA and the MHRA declined to approve it. And lastly, there's curative therapy. So until recently, the only cure for sickle cell disease was an allogeneic stem cell transplant, generally from a matched sibling donor. So that is not only a highly morbid procedure, but also a limited procedure, because how many people have a matched sibling? Gene therapy is changing that these days. So there are, depending on the product you're looking at, there's some use lentiviral vectors, and others use CRISPR to modify autologous stem cells, which are then reinfused to the patient as part of an autologous transplant. The caveat being that those products are extremely expensive, ranging from $2.2 million for one to $3.1 million US for the other. So what about us? What do we have in Canada? So I mentioned all these different drugs. Well, unfortunately, hydroxyurea is the only possible option, and I have it in orange here, not green or some other nice color for a reason which I'll get to, but neither crizanlizumab, voxelotor, nor L-glutamine are Health Canada approved or really accessible to our patients for the most part. So as of April 2025, the problem is that there's actually no readily available Health Canada approved therapies for sickle cell disease. This is pulled straight from the product monograph on the CDA website, and essentially just says that hydroxyurea is really only approved for certain head and neck cancers. It is not still, to this day, not approved for sickle cell disease in Canada, despite all the available evidence and recommendations from multiple guideline bodies. Which means we still prescribe it, but it requires kind of applications on behalf of every single patient for exceptional access or special special authority in BC. So it requires a few extra jumping through hoops just to get access to the only and the mainstay of disease-modifying therapy for this condition. Ironically, the only Health Canada approved product for sickle cell disease right now is one of the gene therapies I mentioned earlier, which has been also conditionally approved by the Canadian Drug Agency. However, the provincial health authorities still have to decide under what circumstances and how they will provide access to the product. So it's still up to the provinces at this point. So in summary, as I've reached my time, sickle cell disease is a chronic disease affecting over 4,000 Canadians with significant and lifelong impacts. There are few Health Canada approved therapies and many barriers to care for patients with sickle cell disease. And so advocacy is needed at all levels of government to improve access to existing and novel therapies in the future. Thank you so much for listening.
Thank you very much, Dr. Murthy. Do we have any questions in the audience?
Okay, so does this work? It does, yes. Increasing hemoglobin F. Any ideas about stopping switching from F to A and ways to modify this in terms of long-term gene therapy?
It's a good question. So one of the gene therapies upregulates hemoglobin F by silencing this BCL11A. That's one of the gene therapies, and that's how it works. So it just increases F, and to the point where people have F levels in the 80-90% after receiving the treatment. The other gene therapy actually involves a modified version of hemoglobin A. So it's not so much a switch as it just has people make a modified form of hemoglobin A instead. So I'm not personally aware of any products that particularly involve switching from F to A, but certainly upregulating F is something that we're doing, yeah.
Thank you. I just wanted to point out, thank you for that excellent talk, the perspective of the blood supplier, which is the promise of gene-edited therapies for this disease are excellent. One of the additional barriers is harvesting the stem cells from these patients. The challenge in taking these people through pheresis, but the fact that they need to have red cell exchanges in advance, often 3 in a row, to get their hemoglobin S level down. And for people with rare or less common blood types, having it to get a high volume. So there will be need for massive coordination between Canadian Blood Services and treaters. It's overcomable, but it's going to be a challenge. And the other issue is the need for platelets now when you put these patients through either stem cell transplant or gene editing therapies, where normally the sickle cell patients don't need platelets, and now they're going to need platelets. And in this heavily transfused group, the likelihood of needing HLA matched platelets is also challenging. So lots of work for us to do at Canadian Blood Services. It's not a slam dunk by any means.
Other questions? Thank you.